infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, hey everybody, this is Robert, and welcome to Outbreak News Interviews. Now, Eastern equine encephalitis virus can cause some really serious pathology. This mosquito-borne virus has been seen in an increase this year in the United States. Typically, in this country, we see an average of 7 human cases on an annual basis. However, so far there's been some 30 human cases reported to date. Massachusetts and Michigan account for more than 20 cases alone. So what is EEEV? What's the pathology? And how do doctors treat patients with this virus? Well, joining me to answer these questions and more is Massachusetts-based infectious disease physician, Stephen LaRosa, MD. Dr. LaRosa, welcome back to the show.
Thanks for having me on the show.
Okay. Well, EEEV is surging this year, including your home state of Massachusetts. Dr. LaRosa, what can you tell us about the virus and the transmission to people?
Yes. So, EEEV has obviously caused a lot of nervousness in my state this year because of some pretty dramatic cases. As you mentioned, it's a mosquito-borne virus. It's a member of the togavirus family in the alpha virus genus, and the virus is passed between wild birds and mosquito populations, and typically affects the eastern seaboard and the coastal segments of Florida.
Now, unfortunately, like I said in the intro, it is a pretty rare infection.
It is, and most people who likely get infected during a season are frankly asymptomatic and never know they have it. But where you get the press is the dramatic cases of encephalitis, which, based on estimates, occurs in about 2% of adults and about 6% of children. And most of these cases are usually clustered in August and September.
However, like I mentioned earlier also, this year we've seen quite a few more cases than the norm, and Massachusetts is a historic hotspot for EEEV, as is my home state of Florida. Dr. LaRosa, what have public health officials up there been saying about the increases this year?
They haven't really stated a particular reason why we're seeing more. They really have been focusing their efforts more on education and also about trying to rearrange, activities so that people are avoiding outdoor activities between dusk and dawn, where the mosquito feeding time is at the highest. Also, some spraying and monitoring, but that's been the extent of it.
Yeah. Now, this virus does, of course, carry some potential serious pathology. Can you talk about the disease in humans?
Yeah, it's an infection that usually incubates once you've been bitten by the mosquito vector for about 4 to 10 days, and it starts off with pretty protean manifestations that are nonspecific: headache, nausea, and vomiting, which when encephalitis sets in is a fairly rapid development of comatose, stuporous presentation. It can look like a stroke, either a brainstem stroke or paralysis, and seizures. So, when it does set in the encephalitis stage, it's a pretty rapid, dramatic presentation. And the issues really become around direct viral damage to the neurons, as well as inflammatory damage that's causing neuronal necrosis and demyelination. And so the major issues become around seizure control and around increased intracranial pressure.
Now, compared to some other mosquito-borne viruses, the fatality rate is significantly higher.
Yeah, a lot of estimates are between 30 and 35% mortality, which is, pretty impressive. And the prognosis tends to be worse if you have more than 500 white cells in your spinal fluid, an elevated intracranial pressure or a decreased Glasgow Coma Scale at presentation. It is the most deadly of all the mosquito-borne arboviruses. So to contrast it with West Nile virus, there's probably far more patients who are infected with West Nile that are asymptomatic. And West Nile tends to present more with flaccid paralysis, maculopapular rash. There are some distinguishing features. Again, of all the mosquito-borne encephalitis, it is the most deadly.
Yeah. And how is it diagnosed in humans?
Typically, you send off both cerebrospinal fluid as well as serum, specifically looking for a EEEV IgM antibody. So CSF IgM is the antibody, is the test of choice, although oftentimes both the CSF and the serum IgM will be positive at the same time. If you're using serum IgMs, you usually typically want to see a rise over time, but you usually send off both specimens when you suspect it.
Yeah, and prior to this phone call, we did discuss this a couple days ago, that you are currently or have treated some EEEV patients. Dr. LaRosa, can you talk about the treatment regimen?
Yeah, unfortunately, I have treated some, but as a general rule, the issues become around seizures. It's very important to do EEGs on these people because about half will be having seizure activity, whether you see it on clinical exam. So it's very important to have appropriate anti-epileptic drugs on board. Intracranial pressure becomes a problem. Increased edema becomes a problem in a lot of patients. So it's often important to have them at a neurologic ICU where they can both measure and control intracranial pressure. A lot of these patients can't protect their airway, so you need they often require mechanical intubation and ventilation to protect their airway, to prevent aspiration, to assure adequate ventilation. Those are the key factors around the supportive care. Now, in terms of therapy, there's no specific therapy. There have been some studies of corticosteroids which actually would have suggested a worse outcome. There have been a few case reports, about 3 in fact, espousing the use of intravenous immunoglobulin or IVIG with benefit. The doses are usually around 0.4 grams per kilogram per day. And there's a variety of reasons why IVIG would work, including neutralizing toxic antibody levels, controlling inflammation, but nobody knows the exact mechanism of action. What seems to be important, though, is having MRI imaging to make sure there's not increased restriction on diffusion-weighted images, which would indicate cell death, neuronal cell death, and that it's too late. So you want to intervene as early as possible before neuronal destruction has set in.
Can you go ahead and tell the audience a little bit about the risk factors for contracting EEEV?
Well, obviously it's around being the mosquito, being unfortunate enough to be around an infected mosquito. It'd be partaking in activities between dawn and dusk. It's very important to obviously have insect repellent on that contains teeth, long sleeves, long pants, if possible. Also very important to get rid of any standing water around your house. So tires, little wading pools, anything that there's water where the mosquitoes can breed, it's important to have that under control.
Well, currently there's not a vaccine for humans, though there is one for equine. Dr. LaRosa, any news for a vaccine against EEEV on the horizon?
There's no particular human vaccine that I know is in late-stage clinical development, although, it is very important to both test the birds that are exchanging the virus with mosquitoes, and also there's frequent testing of horses, and also maintaining good vaccination records in in horses and people with who live in areas where there's a large equine population. But I'm not aware of any vaccine that's in testing right now. It might be wrong.
Okay, well, let's just go ahead and close it out with it. Any final thoughts on EEEV, the situation this year, or anything related to that?
Well, hopefully it's almost over, in terms of this season. In most areas in Massachusetts, a frost is expected within the next couple of weeks. So once there's a frost is set in and the mosquito populations die down, we should be out of the woods for this year. But again, it really is around doing what you can to prevent exposure in terms of when you're performing outdoor activities, protecting yourself with repellent and clothing, etc.
Very good. Well, I wanted to thank you, Dr. Steve LaRosa, for your time and your expertise. Once again, I appreciate it, sir.
Thanks very much.